Okay, thank you. Hello, my name is Marc van deVelde from Leuven, Belgium, and I'm going to give you my second talk on general anesthesia for cesarean section. Sorry. These are my conflicts of interest, but they are not really relevant to this talk. The general anesthesia rate reported in literature for cesarean section is between 0.7 and 51% of cesarean sections, depending on where you work and on the category type of cesarean section. It is higher in category 1, really urgent cesarean deliveries. Reasons to perform a general anesthetic are, of course, patient refusal of regional anesthesia, a failed regional technique, contraindications for a regional technique, and a very dire emergency where you need to find a rapid start of the anesthetic as possible. The conventional regional anesthetic general anesthetic technique has described in textbooks and has remained quite stable and constant over the last 25 to 30 years. The IV induction is usually done by thiopentone, although more and more people are switching to propofol. Succinylcholine is used by many. Cricoid pressure, an intubation of the trachea, and a small dose of a volatile agent. What are the risks associated with general anesthesia? You might have airway problems, you might have superficial anesthesia, you might have blood loss that is higher, and you might have neonatal effects. The airway problems is failure to secure the airway or failure to ventilate and aspiration of gastric contents. Hypertensive episodes as a result of superficial anesthesia and neurologic complications being based on intracranial hemorrhage might be a cause, and awareness, of course, might be a problem as well. With general anesthesia, and especially with volatile agents, there might be higher blood loss than with regional anesthesia. And this has been demonstrated in various studies. There might be transplacental passage of the general anesthetics resulting in neonatal drowsiness, sleepiness, and general anesthesia of the neonate. And as a result of general anesthesia, there have been reports that there is an increased risk of surgical site infections and an increased risk in venous thromboembolism. When regional anesthesia was introduced and when aspiration prophylaxis was introduced, the mortality as a result of anesthesia was significantly decreased. Aspiration prophylaxis was introduced in the late 60s and early 70s, dramatically reducing mortality rates. And since the early 80s, regional anesthesia was broadly implemented, and mortality directly related to anesthesia was eliminated or almost eliminated. So general anesthesia is really an important risk factor and increases significantly the problems. With regional anesthesia, you have far less complications and far less mortality, as this study by Guilmotti in New York has demonstrated. One of the problems is the failure to secure the airway. This is the reported incidences of failed intubation and difficult intubation in a number of publications until the 2010 era. But also in modern studies, there is still a significant problem in failure to secure the airway. Many said this was artificial high incidences, but even in well-designed, well-performed studies from 2020 onwards, you see the same problem. 1 in 180, 1 in 800, 1 in 73, 1 in 300 failed intubations in obstetric patients in various parts of the world. And remember that in non-obstetric patients, the incidence of failed intubation is 1 in 3,000, so 10 times more. Why? Because there is less and less experience, because simple things like the correct head position is forgotten, because there is less time to perform the intubation, because the functional residual capacity of the lungs is reduced, because labor itself changes the airway. Look at the picture on the left. In panel A, you see the airway of the lady prior to the start of the labor. And panel B, when she was 3 to 4 hours in labor, her malampathy changed from malampathy 1 to malampathy 3 over a couple of hours as a result of edema due to the labor process. The second part why there might be a problem with the airway is the aspiration of gastric contents. The risk is probably lower than previously suspected. And we now allow clear liquids and sport drinks in labor, and it's good for the patient and the neonate. But if you're in doubt that the patient has eaten, you might consider gastric ultrasound if you have the availability of a gastric ultrasound, of an ultrasound machine. It is questioned that we should still use cricoid pressure because it might impair the view on the laryngoscope and it might not do what it supposedly does. So there is question whether we should be using cricoid pressure. The second problem is that of superficial anesthesia with hypertension, and hypertension can result at the time of delivery during a cesarean section, result in significant intracranial hemorrhage, which might cause which might cause significant and serious problems. Awareness. The aspiration of gastric contents. Sorry, this is wrong. This is awareness and not aspiration of gastric contents. So awareness as a result of superficial anesthesia is highest in cesarean section surgeries. This is the National Audit Project number 5 from the UK, where they looked at awareness in all types of surgery over a 1-year period. They had 2.8 million general anesthetics recorded, and you can see the incidences of awareness. And the highest incidence is in cesarean section, with 1 patient out of 670 general anesthetics having awareness. Because we are giving too few drugs at the start and at induction, and we also do not give enough to maintain anesthesia. So how to avoid this? Well, there are things with drugs and with the technique we can do. We should give good pre-oxygenation, and we could use fancy things for it. But basically what we should be doing is give good pre-oxygenation with your oxygen face mask, your normal face mask. And that will increase your oxygen content and will result in much more time to perform the intubation, give you much more relaxation, and will result in a better outcome for the patient. High nasal flow oxygenation is probably not the thing forward. There might be slight improvements, but basically I don't think it can be so important. More important is do the simple thing of adequate pre-oxygenation for 4 or 6 vital breaths or 1 or 2 minutes of good pre-oxygenation. Cricoid pressure is still used, but you should also be able to release it when the first intubation attempt fails, and also give some gentle mask ventilation to maintain oxygen reserve in these patients. Do not avoid it, as was suggested in the past that you should be doing. If the visualization of the larynx is difficult when you have applied cricoid pressure, you can release it. It will improve the situation for the intubation. If you have the availability of a video laryngoscope in your hospitals, use the video laryngoscope as your primary target, because as your primary method of intubation, because it will certainly dramatically reduce the incidence of difficult intubations. So conclusions. This is the video laryngoscopes are certainly important and should be used if, of course, you have the availability of them. It is also safe to perform intubations, to avoid intubation in elective cases, and to use a second-generation laryngeal mask airway. In patients that have fasted, in patients that are not obese, in patients that have no risk factors for respiration. There are more than 7,000 reported patients in literature where there's been no real problem with aspiration, and where they were where they use the laryngeal mask airway as a primary method of securing the airway. Of course, you should only be doing that in a low-risk population. As I mentioned, that is an important thing. But remember that in all airway algorithms, if the intubation, a normal endotracheal intubation, fails, in your airway algorithm, a laryngeal mask airway is the primary savior of the day. It is the second line try if your intubation has failed. We are using now propofol as a standard induction agent. I'm not going to discuss that because I think everybody does it now worldwide, although it's still in the textbooks. But there is some discussion about rocuronium. In this non-inferiority trial, rocuronium in a high dose had similar intubation conditions than succinylcholine, with less myalgia afterwards. For sure, it is effective. However, in this trial, there was a coincidental finding of lower 1-minute Epgar scores, but they have been avoided. The effect of succinylmetonium versus rocuronium on onset of oxygen desaturation during apnea following a rapid sequence induction has been tested, and they have been effective. The rapid sequence induction and intubation with rocuronium compared with succinylcholine as a randomized controlled trial has been tested, and you can see that the time to start the intubation is similar, and there is better outcomes in this study. An opioid prior to delivery can be given as well, and in this instance it's remifentanil, and this has been extremely useful to be used with very minimal side effects. In prospective trials, using remifentanil has been shown to be very and highly effective as well. The maternal effects of the opioid prior to delivery are quite stable anesthetic conditions, no hypertensive peaks, no awareness, and this is therefore a very useful drug to be used prior to delivery of the baby. And also the neonatal effects, as I said, are minimal and quite avoidable. So with adaptations in the technique, with adaptations in the drugs that are used, you could give significant improvements in the protocols. And therefore, I would propose that everybody uses propofol, short-acting opioids prior to delivery, remifentanil or alfentanil, cricoid pressure, but only use it liberally if you can release it. Do a mask ventilation, and you can use an LMA as a rescue when a first attempt of intubation fails in low-risk patients. Thank you very much for your attention.